My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. Today's event is entitled Dental Hygiene Scope of Practice, Why It Matters. Jean Moore is the director of the Center for Health Workforce Studies located at the School of Public Health at the University of Albany. And of course, the Center for Health Workforce Studies houses both HWTAC and an Oral Health Workforce Research Center, whose work she's going to be talking about today. Jean?
Hi, everyone. So today's webinar examines dental hygiene scope of practice and work done by the Oral Health Workforce Research Center to study it more closely. And so, as many of you may know, the Oral Health Workforce Research Center is a cooperative agreement with HRSA. It's a partnership between Center for Health Workforce Studies and the one at UCSF, University of California, San Francisco. And essentially, it supports workforce research aimed at expanding access to oral health services for vulnerable populations. There are two co-sponsors for this webinar. One is the Health Workforce Technical Assistance Center, which Dave is the director of, and also based at the Center for Health Workforce Studies. And a second partner is the Schuyler Center for Analysis and Advocacy. And it's a New York State not-for-profit policy analysis and advocacy organization that works to improve health, welfare, human services for all New Yorkers, particularly the poor. And they have a very, very strong commitment to improving access to oral health services. And in fact, have a CareQuest grant that is designed to consider workforce strategies going forward. So I want to start by saying that, and for many of you, I'm sure this is not news, but poor oral health is a public health problem. And quite honestly, it has been for decades. So in 2000, the Surgeon General issued a report called Oral Health in America. And that report was updated in 2021 by NIDCR. And quite frankly, the issues really seem to have not changed very substantially. Dental caries remains a very common chronic disease of childhood. And despite what we know about links between oral and physical health, there's substantial unmet need for oral health services that can be tied to a variety of issues, included siloed delivery system, separate payment mechanisms, the fact that many state Medicaid programs do not cover adult dental, and many dentists do not participate in Medicaid programs, or sometimes they might enroll, but not necessarily treat many Medicaid patients. So things are changing. And there's been growing attention to value-based care, a focus on prevention, early intervention, improving oral health literacy, which I think is a critically important concept, growing importance of risk assessment for triage, use of technology to improve access, and integration of oral health with primary care and behavioral health. So some of the workforce impacts of these changes include team-based care. And when I say team-based, I mean collaborative team-based care, not hierarchical. New workforce models emerging, dental therapists, community dental health coordinators, engagement of medical professionals, another important one. As we integrate oral health with primary care, there's some training of the primary care health workforce to screen, refer, apply fluoride, especially for children. And interprofessional education for oral health screening, including Smiles for Life. One of the things that's happening as well is expanding roles for the existing workforce. So looking at dental assistants with broader scope of practice and many different um, uh, approaches to dental hygiene. Public health dental hygienists, independent practice dental hygienists, collaborative practice dental hygienists. So that actually brings us to the issue of scope of practice. So what do we mean by scope of practice? There's actually a couple of different definitions, and it's important to understand what they are and how they're different. So professional scope of practice, also known as professional competence, describes the services a health professional is trained and competent to perform. Legal scope of practice is based on state-specific practice acts, and it defines what services a health professional is allowed to provide under what conditions in a given state. So, you'd think that legal scope of practice and professional competence overlap, but the amount of overlap varies by state and by profession. So back in 2001, researchers here at the center recognized the fact that dental hygiene scope of practice really varied considerably by state. Differences in the tasks that were permitted, the required supervision. So in 2001, we decided to quantify dental hygiene scope of practice and create what we call the Dental Hygiene Professional Practice Index. And what that entailed was convening an advisory board of national experts, focus groups, interviews with many dental hygienists, and producing a scoring instrument that contained 69 variables grouped into 4 categories: regulations, supervision, tasks, reimbursement. And from there, we conducted an exhaustive examination of statutes and regulations in each state to say, is it allowed? The way the index was designed, each variable was scored based on its impact on community-based practice. So a maximum score for the entire index was 100, minimum score 0. And we used this instrument twice. To score state-level dental hygiene scope of practice in 2001, and then again in 2014. So when we looked at the scores, and again, bear in mind, same index, in 2001, the lowest scoring state was West Virginia, highest scoring Colorado, so 10 compared to 97. And in 2014, Alabama was the lowest with 18, Maine 98. But the mean score had changed between the 2 time periods. So mean score in 2001 was 43.5, and it jumped to 57.6 in 2014. So it was clear to us that things were changing. So we decided that we wanted to update the Dental Hygiene Professional Practice Index in 2016. Again, recognizing that dental hygiene roles and responsibilities include more autonomy, more technology, more settings for care delivery, among others. And once again, we used our design process included outreach to dental hygienists. And at the end of the day, some variables were retained or modified. We had fewer variables overall. New variables were added. And once again, scores were in the range of 7 in Mississippi to 86 in Maine. So again, we were pleased to see that scores were a bit higher overall, that they tended to be on the higher end of the scale. Some states were innovators and created some new and important opportunities for dental hygienists. Other states moved more slowly, and some low-scoring states really just didn't move out of the lower rankings very much. So we finished all this work and we said, okay, what does variation in dental hygiene scope of practice actually matter? What's the point here? So we decided we wanted to take a closer look at that. And the research question at hand was, do more expansive dental hygiene scopes of practice allowing more autonomy in providing preventive services, especially in community-based settings, impact oral health outcomes? So we actually conducted 3 separate studies using the DHPPI in 2001, 2014, 2016, used multi-level logistic modeling and a variety of data sources for state level information and a BRFIS for individual level information. So the individual level data, and again, the one I'm reporting on is the one where we used the 2014 DHPPI, although the analyses were consistent across the different time periods. But we looked at demographics, we looked at income, we looked at education, marital status, last visit to a dentist, number of permanent teeth removed due to decay or disease. And then for the state level variables, the usual suspects that could impact on access to oral health services. So number of dentists, number of hygienists, percent of the state population with access to fluoridated water. And again, the state level variable, the DHPPI, and in this case, it was for 2014. Results. What we found was that scope of practice mattered. The 2014 DHPPI scores exerted a positive and significant impact on adult oral health. More expansive scope of practice for dental hygienists in states was positively and significantly associated with having no teeth removed due to decay or disease among individuals living in that state. So we wound up taking this research and publishing it in Health Affairs in 2016, and the citation is there on the slide. And Health Affairs selected it as one of the top 10 research studies they had published that year. So, of course, you can imagine we were ecstatic. We said, wow, this is great. Look at this. Broader scopes of practice for hygienists associated with better state-level oral health outcomes. Then we kind of stopped dead in our tracks and said, but the people who really need to see this are probably not going to be reading Health Affairs or looking at multi-level modeling in a paper. So we decided that we needed to find a way to help people, and with this, I'm really talking about policymakers, planners, advocates, to better understand this variation and what it means for their state. So we decided we wanted to build an infographic that we thought could achieve that goal. So once again, we collaborated with ADHA, the National Dental Hygiene Association, and we conducted a series of focus groups with dental hygiene leaders. And specifically, our question was, what are the tasks and functions that dental hygienists can do that supports their ability to provide care in community-based settings? And it was an extremely helpful process. So these are the tasks and functions we included in the infographic. And we actually went back into the state's laws, regulations, policies to say, can hygienists perform these functions in a particular state? So again, we wanted to make sure we accurately captured current legal conditions for practice. And I will tell you that we've also made efforts to update the infographic. We did so in 2018 and again in 2019. So this is where we arrived. We have this scope of practice infographic that shows particular things that dental hygienists are capable of doing, but may or may not be allowed to do depending on the state. So I will tell you that this infographic at some level kind of has taken on a life of its own. There's just been tremendous interest in the infographic. There have been I've seen it in any number of presentations made at oral health conferences. I was at one session where somebody showed this, had stripped all the identifiers off, and somebody said, "Where'd you get that?" And the woman who was presenting said, "Gee, I really don't know." And of course, I raised my hand and said, "Hey, I know." But anyway, I think that being able to have some shorthand that allows policymakers to understand issues around dental hygiene scope of practice and why it's important for hygienists to be able to practice to the full extent of their training and competence. So again, it's very clear that the more dental hygienists can do within their scope of practice, the more effectively they can provide care to high-need populations in community-based settings and clearly achieve better outcomes. I think that I would characterize this as a work in progress. Occasionally, we'll get emails from advocates in states telling us about changes that occur, which we've duly noted. Right now we're in the process of trying to update the infographic by checking with dental hygiene leadership in different states to say, what's changed in your state since we last updated the infographic? The other thing we want to do and are looking very mindfully at the opportunity to update the Dental Hygiene Professional Practice Index. So remember, the one we're using, at this moment was built in 2016. And quite honestly, the world continues to change, and we need to, if this is going to be meaningful, we really need to keep up with that. So I think that we hope to get resources that allow us to update the index itself. And also, we'd like to go forward with plans to monitor who's using it, how they're using it, and what impacts it's had on dental hygiene scope of practice state policy. So thank you. I just want to acknowledge that the work was supported by the HRSA grant, the Oral Health Workforce Research Center HRSA grant. And as you can imagine, this work occurred over a number of years, and there are a number of different people who are involved in different aspects of it, and I want to acknowledge all of them. So thank you. I'm interested in hearing your questions.
All right, thank you, Jean. That was a wonderful presentation. What are dentists saying about expanding scope of practice or allowing dental hygienists to practice to full scope?
I mean, that's an extremely interesting question. And as many of you may know, I think there are always struggles between different professions regarding letting people do more, as it were. So honestly, I think there have been times when dentists have not supported efforts to expand scope of practice. And again, I mean, one question I have is, we want to expand the scope of hygienists who are providing preventive care. They're certainly not kind of trespassing on um, the scope of practice of dentists like dental therapists do, frankly. So it's hard to imagine what's bad about that. And I will tell you that when you talk to individual dentists, particularly those working in safety net areas, they're very supportive of these efforts. But I think that at times organized dentistry gets a little nervous about scopes of practice that are too broad. I will tell you that New York has been working, the folks in New York have been working diligently to try to broaden scope of practice for hygienists here, and it hasn't yet happened, and for a variety of reasons, and some of which is sometimes it's just hard to get people's attention about something that might seem small, minor, that really isn't. So again, I think that when you're trying to make changes that require change to state law, it's a long haul, but it's certainly worth the effort. I will tell you that we have a plan to have another webinar on dental hygiene toward the end of this month, and we hope to have the details out shortly. But looking at what dental hygienists can do who work in states that allow them broader scopes of practice. And it's just very clear that they can really have some impacts. So it's definitely worthwhile.
All right, thank you, Jean. Has this information been shared directly with state dental boards that oversee licensing?
We have not shared it directly with dental boards. And I don't think I mean, we put the information out, we try to make sure that people have access to the information, and we're always willing to talk with people about it. To be quite honest, one of our target audiences who I think are most important and are probably key to the answer to this are the oral health coalitions in a state. Oral health coalitions that understand access barriers and issues and can use this information to make sure people understand where their state stands. By the way, in the chat, someone mentioned it depends on the dentist you asked about what they think about scope of practice changes. And again, I think that public health dentists are probably quite supportive. The ones I know are. Again, I think that it may be less appealing for other dentists and organized dentistry as a whole.
Wonderful. Hey, Jeffrey's preparing for the upcoming semester, and he wants to give his students the most current information. Is there more likelihood for expanded practice, collaborative practice, or CDHC's ADA model?
Something I want to say that things are changing fairly quickly. So I think that efforts to create more CDHCs are on a lot of radar screens. I think that dental therapy is a huge issue. And in fact, we may be doing some webinars on dental therapy in the fall, but they practice in a number of tribal areas. They practice in some states, statewide. So I think that as more and more states encounter pretty serious access barriers to oral health services and try to think through workforce solutions, this comes up a lot. In fact, there's an infographic on our the Oral Health Workforce Research Center website that looks at kind of the state of affairs around dental therapy in the country, and what states allow it, what tribal areas allow it, and where it's headed. And that we try very hard to keep updated. We work with Community Catalyst, who tracks it pretty closely.
Speaking of infographics, when will an updated infographic be available?
We are actually working on that as we speak. We collaborated with ADHA, our usual partner, and reached out to the different state dental hygiene associations and said, hey, we're updating our infographic. Tell us what's changed. So we have the information and we're in the process of updating. So I would say probably within the next month or so, and you should be able to, when you look at the infographic itself, look at the date of the last update, because again, our goal is to get a 2024 update to the infographic as soon as we can.
And, there is a comment in the chat. It has been my experience that dentists are concerned about the quality of care provided by dental hygienists in public health settings. A follow-up study which examines the quality of care provided in public health settings might be interesting.
Yep, I agree completely. I think that we don't know enough about it, but I will tell you that with some of the studies that I've seen, things appear to be pretty positive. But I agree, we need to be more systematic, and I think it's definitely worth studies understanding. And actually, I would invite you to attend the session we're hoping to convene at the end of the month, where dental hygienists who do enjoy broader scopes of practice and are, more likely to be found in community-based settings, what their experience has been. And the other thing I want to say is, they certainly don't do it in a vacuum. They're part of a team. I think that any dental hygienist with kind of a certain amount of autonomy is connected to a group, a team, most likely with a dentist or dentists being on that team. So I don't think anybody's looking to hang out a shingle. I think it's a matter of, expanding capacity by building collaborative teams.
Yeah, and actually, I'll just find out on a side note, like as Sheen mentioned earlier, there's HJ is one of 9 health workforce research centers, as is the Oral Health Workforce Research Center. And there is a new public health workforce research center too, which just got online. So perhaps an opportunity down the line. It seems like there continues to be an I can't even pronounce words, an exacerbation of workforce shortages, particularly in mid-level providers. How might the opportunities to practice up to the top of your licensure, up to the top of your scope of practice, influence more providers coming into the field?
There are a lot of moving parts to the answer here. I think that we really failed to appreciate the impacts and the long-term impacts that COVID has had on health workforce broadly, but oral health workforce specifically. So we've done some studies around burnout, job satisfaction, recruitment, retention difficulties being experienced by oral health providers. There are challenges, and I think that, is it a viable strategy to kind of look at what people do and allow them opportunities to do more? Again, I think it's not about having them do stuff that they weren't trained and capable of doing, but it's allowing for a recognition of what they were trained and capable of doing, and letting them do it under the circumstances that they're in. So I feel like that certainly could be a strategy, but I think we've also got to figure out how, to kind of better understand what's causing people to burn out and what can we do to improve working conditions. We did a study, just wrapping up a study and looking at hospitals in New York about, issues related to nursing recruitment and retention. One of the things that came up again and again was workplace violence, that there's a lot more of it. It's a lot more challenging, and it's much more intimidating to people. I had a vet appointment 2 weeks ago, and there was this big sign that said, just want to let you know, we will not tolerate verbal abuse to staff, to other patients, and we may ask you to leave. So it's pervasive. I don't think it's just in healthcare. I don't think it's just in oral health, but I think that being aware of the impact of things like that on providers and decisions to stay in a job or not. I mean, one of the concerns in healthcare was that a lot of folks kind of moved out of, clinical roles to take roles that were a little less stressful. And I guess we need to understand, what are the stress levels? What can we do about it?
Okay. Well, let's move on to the next question. There's quite a few lined up here for you, so I hope you have the rest of the afternoon.
Great.
Is it possible to expand scope of practice without creating independent practice?
Absolutely. I mean, there are all kinds of variations on what this entails. I mean, I think the question of, can people work to the full extent of their training and capability? And I don't think that means it's autonomous. They may have more ability to do things independently, but in a relationship with a supervisor who feels comfortable allowing that individual to do these sorts of things. Many years ago, we did a case study of a school-based clinic, and the law of that state required that a dentist be physically present while the hygienist was providing care. And this was a remote location. They wound up using their resources for a teledentistry link, so the dentist was available while the hygienist was providing care. And I started thinking to myself, can you imagine what more you could do with that money if you didn't have to do that? And as long as the dentist was available for consultation, I mean, the dentist was quite comfortable with the hygienist. They'd known each other for years. That, this was not a situation where, there wasn't a lot of trust. I mean, that was already there, but the way the law was written, she had to have kind of this person available and visible while she provided care in very remote settings.
Okay. Well, next question. It seems that scope of practice and levels of supervision are being combined for this presentation. In policy advocacy, we tend to delineate this very purposefully. How does the Oral Health Workforce Research Center and the instrument they use for this infographic delineate these two?
The DHPPI, and I mentioned this earlier, broke into, I think we said, 4 different categories. So it was regulation, like who licenses, et cetera, what are the rules around licensing, supervision, tasks, and reimbursement. So they really are treated separately in the DPPI that we've developed. So, and importantly so, I think.
Okay. In New York, we have 2 tiers of dental assistance. Do you think that this is the direction dental hygiene could be going?
You know, I honestly don't know. I think there have been some efforts to try to improve dental hygiene scope of practice in New York, and I think there's a bill out there right now, but I don't know if it creates a two-tiered system. I really I don't know that. I think there were some considerations for getting hygienists into settings, improving their ability to access settings like nursing homes, like school-based clinics, Head Start programs, whatever. So I am not familiar with the what's in the proposed law right now, but I think that it was designed with that in mind.
Okay, and I guess this next one's a consideration, for the infographic. Would it be possible to include the states that allowed hygienists to include the provision of SDF?
Done. Go to the Oral Health Workforce Research Center website. We actually built an infographic that looks at the use of, or the ability of hygienists to provide SDF. We realized it was important. We looked at trying to wedge it into the infographic I showed you and just said, nope, we got to treat it separately. So it's there and it's available. Again, there are a few infographics on the Oral Health Workforce Research Center website that I think may be of interest to you. The one I showed you today, the dental therapy one, and the silver diamine fluoride one. And we also did one around teledentistry and barriers, facilitators to teledentistry services that I think would be of interest as well.
Okay, thank you. That's a good comment there. If the goal is increasing serving the underserved, is there a possibility of an expanded RDH function practicing only in Medicaid offices or clinics?
So that's a very interesting question, and I will tell you that for when the law in Minnesota authorized dental therapists, the law required that the dental therapist have half their caseload be drawn from underserved populations. And that actually resulted in the vast majority of dental therapists working in the safety net that, in order to kind of meet that requirement. And to be honest, I think safety net providers were just thrilled to have them. So, that worked out. And I think that when we talk about oral health access issues and barriers, I think you're really talking about underserved populations. So certainly making sure that safety net providers have access to hygienists with broader scopes of practice just makes an awful lot of sense, because they're treating the populations who really need these services.
Thank you. Well, next up, there is a big shortage of dental hygienists right now, which seems to be driven by people leaving the workforce and not enough people graduating and coming into the workforce. Can allowing hygienists to do more help keep folks in the workforce?
Yeah, good question. And I think that dental hygiene is not the only profession where this is happening. I think that we're really struggling as we see the baby boomers exit. And again, the pandemic certainly didn't help that. And it's hard to know about production and understanding what the production barriers are. For example, in nursing, that, where we looked at, how is the educational pipeline affected by the pandemic, one thing that happened was that clinical training sites said to nurse education programs, really sorry, but we can't take your students. We're dealing with a crisis that, just wouldn't allow for that. So the nurse education, the deans and directors figured out a strategy that said, okay, let's use simulation to help students get the skills they need so they can graduate on time because we need them so badly. So that actually worked pretty well, except these new grads came out with much less hands-on experience with patients and much less prepared for transition to practice. So it wasn't that they were producing less nurses. I mean, when we look at New York anyway, pretty close to what was expected, but they just weren't sticking around because they were so overwhelmed to be put in a situation that they just weren't prepared for. Now, many of the providers kind of studied this and said, we got to change this, and began offering residency programs and said, hey, look, we are going to help you transition to practice. We're going to provide support for you. And so the effort included residencies with experienced nurses mentoring new nurses. So I feel like we need to better understand what the issues are around the production of hygienists. Are there fewer, or are they heading into different areas of opportunity? So what do we know about the pipeline in order to figure out what we ought to be trying to do to fix it?
Okay, and really kind of a follow-up. What do you think is the best way to educate the public about the potential scope, current, and expanded of dental hygienists? I find the public doesn't know what a dental hygienist does.
That's a great question. So, to be honest, I feel like sometimes when you talk about scope of practice, people's eyes start to glaze over, like, what the heck is she talking about? And, the distinction I talked about earlier around hygienist professional competence versus legal scope of practice. I mean, it's key to understanding this. So somehow I think that if there are efforts to sort of lobby for change, it should be about, contrasting what hygienists are capable of doing versus what they're allowed to do. And to me, I think that's the starting point. And to be honest, the place that I would begin is with planners, policymakers, folks where they're struggling with access issues. They're looking for strategies. Here's some low-hanging fruit to think about. So I feel like understanding who that audience ought to be and what messages you want to send. Again, scope of practice isn't as straightforward as it appears. You got to scratch below the surface a little bit to kind of fully understand what some of these issues are. But again, we hear feedback from oral health coalitions who've just been great supporters of the infographic, saying it really helped us get people to understand what we were trying to say. So,
well, moving on then for the next question. Where can I obtain more information on practice plans for the general supervision of registered dental hygienists working in public and community settings?
So number one, you got to go state by state. I mean, it's different in different states. And I might start by asking the American Dental Hygiene Association, because if anybody is tracking it, they might be. And understanding how effectively it works. I mean, someone asked earlier about, hey, how do we know about the quality of care being provided in these settings? And obviously, supervision is an important part of that. So I feel like there could be some opportunity to take a closer look and better understand how that plays out. The other thing I just want to point out is that sometimes what you're allowed to do on paper isn't always what happens. So we had a couple of folks say to us, yeah, it's in the law, but we still don't do it. And I can't tell you that I understand why completely. But I guess the point is that understanding the reality versus the possibilities are part of what I think you need to understand.
And I'm not quite sure of the next question, Gene. Can you see it?
It's not a question, but I agree. I think
Okay.
dental hygiene diagnosis and treatment planning would be a great expanded function, particularly utilizing teledentistry.
Okay, great. I was reading.
So I agree.
Okay, well, can you comment on insurance reimbursement for RDH as the rendering provider? Many third-party payers only recognize the dentist as the rendering provider.
So I have not taken a closer look at that, but I know that it's been a huge problem for nurse practitioners and physician assistants where um, uh, billing would go through the physician when in fact the provision of care was with another professional. And I think there have been some efforts to change that in Dave, NPI. Didn't NPI
Yes.
try to do something around that so you could actually separate out who got who billed, but who provided the care? And you need something like that. But I will tell you, it is very, very hard to get insurance data generally. And dental insurance, I think is probably twice as hard. So those data could be very, very valuable if you could get access to them, but it certainly isn't easy.
Okay, and the next one's also more of a comment. New York State proposed legislation on collaborative practice that would establish an RDH-CP. Do you have any thoughts or?
Hey, Beth, great news.
Okay, okay.
I just want to say that there is a lot happening in this arena, and I think that it has a lot to do with the fact that we all recognize how problematic the access issues are and efforts to try to resolve them. You know, they really require collaboration, and I know that Beth and her team at the State Hygiene Association are working closely with folks at the Schuyler Center, with the Dental Society, with others to try to arrive at something that is viable. And, I think that's how you get there in most cases.
Okay, and we're down to our final question or thought here. And it's, something to include for the future or a different graph. State Medicaid agencies that have activated the CPT code for SDFs. So medical healthcare providers can be reimbursed for providing SDF as part of primary medical care.
One of the things that didn't come up in the questions that kind of surprised me was about the fact that, as we move toward more oral health integration with primary care, that there are increased efforts to, actually it's a two-way street, but I would say that engage primary care providers in conducting oral health assessments and applying SDF, doing, fluoride varnishes of all stripes. But the point is that as you move to integration, it can really improve outcomes, and it can really engage patients more. I was at an FQHC on a site visit where they had effectively integrated oral health with primary care. And there was a hygienist who went to participate in all of the well child visits, baby on up. And I was talking to her afterwards. I mean, what a great idea, right? And she said, the best thing is knowing I've connected with parents before they show up with kids who have bombed out mouths. she said, that to me is probably one of the most satisfying things I've ever done. And knowing that we've, worked to make this, possible. Again, improving oral health literacy. I think that absolutely critical. So.
Okay, Gene, well, we've come to the end of our questions. With that said, do you have any other thoughts you'd like to share with our audience? Or put another way, if there's one thing you'd like people to come away with from this presentation and Q&A session, what would it be?
Gosh, there are so many issues, but I guess my feeling is that we understand that we should be striving for more convergence between legal scope of practice and professional competence. And I think that for those of us in a position to kind of move the move the dial in the right direction, that would be so important. I think helping hygienists do what they're trained and capable of doing and improving access to oral health care in the process is the right thing to do. So thank you.
That said, I don't think we have any too much. I guess a final comment here, Gene, if you want to read it.
Oh, RDHs are educated as opposed to trained. Sorry, misspoke. I apologize.
It
I know
happens.
they are.
It happens. Well, thank you, Gene. It was a wonderful presentation, and thank you for the audience to attending our event today. I hope to see you again in the future, and of course, have a wonderful afternoon.